I call upon Dr. Sunil Kota to the dais. Dr. Sunil is a prolific speaker with 79 peer-reviewed publications, 44 in diabetes alone, he has got several awards to his credit, and he's even got Dr. V.D. Nadgowda oration at RSSD annual conference held in Bangalore in November 2014. I welcome you to Salem, sir, and over to you.
Thank you so much for that kind words of introduction. Thanks to organizing team led by Sakti and the ever-smiling Prem for inviting me to this serene place of Salem. And my mandate is to take you through the medical therapy, and the reality is far from expectation. That's what the honky-dory type of expectation, what the patient expects from you. And why we have this obesity symposium early in the morning is the fact that it has sheer numbers and the burgeoning prevalence, and at the same time it has implications. Those are metabolic in the form of sick fat disease, the mechanical in the form of fat mass disease. Then there are some fancy terms like monetary and mental implications as well. With this brief preamble, I am going to take you through my presentation, which will have the points mentioned on the slide. First of all, let's talk briefly about the goals. Ideal outcome would be to get the patient to normal body weight, which is actually unrealistic. That's why the term success or effectiveness is used, which is defined as weight loss to the tune of more than 5% at the end of 3 to 6 months, and it should be sustained. And drug trials define good response as weight loss of 10 to 15%, excellent response as weight loss more than 15%. Duration, several trials have looked at duration of 3 to 6 months, but that would not be long enough to give you good metabolic benefits. The only drug, Orlistat, which has 4-year long-term data. We know that obesity cannot be cured. It can be controlled. Once the drug reaches its maximum efficacious dose, there would not be further weight loss, and there is a chance of rebound once the drug is stopped. And when there are comorbid conditions like diabetes, cardiovascular disorders, hypertension, depression and behavioral problems, we are supposed to look at drugs which will not have that much of weight gain issues. So how much we are aiming at? 5% weight loss improves beta cell function and insulin sensitivity. 5 to 10% reverses pre-diabetes, lowers sugar, BP and cholesterol. And it is the 16 to 32% weight loss which is associated with diabetes remission and decrease in all-cause mortality. And what does the FDA have in store for the newer drugs? The PSWL, that is the placebo-subtracted weight loss, should be more than equal to 5% at 1 year, and at least 35% of the population should achieve this goal. EMA says the absolute weight loss should be more than equal to 10% at 1 year, and the PSWL can be more than equal to 5%, and additionally there should be improvement in cardiovascular risk factors. So what are the indications? The Endocrine Society in 2015 says above a BMI of 25, those are the candidates for behavioral therapy, and above 30, the pharmacotherapy should be instituted, but with BMI more than 27, with any of the comorbidities, the pharmacotherapy can be instituted. But we Indians are a bit underprivileged. The Indian guidelines says BMI more than 27 or more than 25 with comorbidities, probably those are the ones who should be receiving the pharmacotherapy. So the medical management, which is the crux of my presentation, I would be talking about a number of drugs which are FDA approved, but many times people have a tussle in the mind, do the pharmacotherapy score over the high intensity lifestyle intervention? Probably this slide puts the doubts to rest. Most of the studies tell us that both of them are same, except that of the phentermine topiramate, which would be scoring over lifestyle intervention. And good number of times the patient comes to you with a question that, doctor, I want to take the tablet, but I won't be adhering to the strict diet and lifestyle regime. But this slide tells us that the combination of both of those would be definitely scoring over either of the treatment alone. And in terms of the weight loss accorded, the drug having maximum weight loss is phentermine topiramate 10.2 kgs, then the bupropion around 8 kgs. So these are the drugs. Those are approved. I will be taking you through the journey of these basic 5 drugs and some of the upcoming ones as well. Orlistat, which we all have been using, approved in 2007. It leads to inhibition of pancreatic and gastric lipase enzymes, and thereby leading to a state of fat malabsorption. Doses has to be 120 milligram thrice daily, but if the patient is intolerant, you can start at a dose of 60 milligram thrice daily. Placebo subtracted weight loss is 2.6 kg. The side effects being oily spotting, flatus, flatulence, defecation urgency, increased defecation, and there are some other side effects like non-specific headache, dizziness, nausea, vomiting, and there are some serious, very uncommon side effects like pancreatitis, hepatitis, cholecystitis, and chances of nephrolithiasis also. And we have these contraindications like chronic malabsorption, known cholestasis, pregnancy, and we are supposed to monitor for this condition. One very important point, the patient has to be counseled that the fat intake should be less than 30% of the total energy intake for the day, and levothyroxine, if it is being taken, there should be a gap of minimum 4 hours. So this is the famous Zendos study which looked at orlistat in prevention of diabetes. You can see in the first year the weight loss was greater in the orlistat, and there was a 37.3% risk reduction in diabetes. And even after the termination of the trial, the patients were studied for another 3 years after stopping the drug, and the patients who were initially receiving orlistat, they were having 6% lesser weight than that of the ones who were using placebo. And this is the drug which has maximum duration of study, that is 4 years. You can see at the end of 4 years, the percentage of total body weight that is greater than placebo stands at around 2.6%. The lorcaserin, which is a selective 5-HT2C receptor agonist, we had this precursors in the form of fenfluramine and dexfenfluramine, which used to act at 2A and 2B, which are associated with valvular side effects, but this one is very specific towards 2C. Approved in June 2012, dosage is 10 mg BD, the weight loss PSW is 3.2 kgs. The common side effects being headache, dizziness, fatigue, nausea, dry mouth, dry eye, constipation, and patients with type 2 diabetes, there can be chances of hypoglycemia. There are some uncommon side effects like upper respiratory tract infection, nasopharyngitis, incidence of valvulopathy is less, and the contraindications being pregnancy, breastfeeding, severe renal dysfunction, co-intake of other serotonergic drugs. So there are studies in favor of this molecule. Those are the Bloom, Blossom, and the Bloom DM. You can see the mean weight loss at the end of 52 weeks is somewhere between 4.7 to 5.8 kg, and the percentage of patients having more than 5% weight loss is somewhere between 40 to 48%. That is above the FDA recommendation. Liraglutide, which we all have been using for diabetes, it is a GLP-1 agonist, but it was approved as an anti-obesity drug in 2015. Maximum dose that we can use is 3 mg, and the patient has to be re-evaluated at the end of 16 weeks. Mean weight loss is around, the placebo subtracted weight loss is around 5.3 kg. The side effects are same as that of the ones that we use, the nausea, vomiting, constipation, hypoglycemia, diarrhea, headache, fatigue. There are chances of pancreatic involvement as well. There are chances of dyspepsia, tachycardia, and the contraindications, the severe renal or hepatic dysfunction, personal or family history of MTC or MEN 2A or 2B, pregnancy, breastfeeding, pancreatitis. The oral GLP-1 analog, that is the semaglutide, is an upcoming option for treatment of obesity as well. So this is a study in 2012 where liraglutide at different doses was compared with that of the placebo and the orlistat, and at each dose the weight reduction was significantly higher than that of the placebo, but to go ahead of the orlistat, the doses minimum required is 2.4 mg subcutaneously daily. And these are the studies which led to its approval as an anti-obesity drug. The scale obesity and pre-diabetes study, where liraglutide 3 mg was compared versus placebo, and there was 8 versus 2.6% weight loss in favor of liraglutide. Then patients having diabetes were also tested. That scale diabetes study, liraglutide 3 and 1.8 mg had weight loss to the tune of 6 and 4.7% versus 2% with the placebo group. This again is very important study, the scale maintenance study, where initially the patients were put on intense lifestyle modification, and the ones who had more than equal to 5% weight loss, though they were the ones who were taken into the study. And even after the diet and lifestyle induced 5% weight loss, the ones who had liraglutide had additional 6.2% weight loss, and that really is significant. Then we have these noradrenergic sympathomimetics. The lower two, the sibutramine and phenylpropanolone, are nowhere approved. The ones, the phentermine, diethylpropion, benzoamphetamine, phendimetrazine are the ones which are approved, but the phentermine is the one which is being currently used, the most commonly used in US. It is approved in 1959, but it is approved only for short-term use, that is less than 12 weeks. And this is the study, EQUATE study, where the phentermine topiramate combination was compared with the either of the drugs used alone. And if you can have a look at the table at the bottom, fenfluramine at the doses of 7.5 or 15 milligram, 40 to 45% of patients were having achievement of weight loss more than 5%. And this was a beautiful study of 36 weeks where placebo was compared with continuous or intermittent of phentermine, where the phentermine was being given for 4 weeks, then the 4 week of rest, and this was being followed alternatively. And at the end of 36 weeks, patients using alternate therapy had weight loss to the tune of 13.2 kgs, and the ones who were using continuous phentermine therapy had weight loss to the tune of 12.7 kgs. Side effects, the typical sympathomimetic effects like increase in heart rate, blood pressure, insomnia, dry mouth, constipation, irritability, and that's why it is contraindicated in patients with coronary heart disease, hypertension, hyperthyroidism, or in patients with a history of drug abuse. So this was the infamous cow trial which knocked the sibutramine out of the picture, but it was a flawed trial because of several reasons. There was an increase in risk of non-fatal MI and non-fatal stroke. Then the phentermine topiramate combination, the phentermine takes care of the immediate effect and the topiramate acts on a long run. It basically reduces the food craving and abolishes the food addictive behavior. Doses started at a very low dose of 3.75 and 23 can go up to 15 and 92 milligram. The placebo subtracted weight loss is maximum, that is 8.8 kgs. The side effects being insomnia, dry mouth, constipation, paresthesia, nausea, dizziness. So the combination was approved in 2012. As you can see, initially you can upscale in a period of 2 weeks each, and at the end of the maximal dose you can again re-evaluate after 12 weeks. So these are the side effects, the predominant being dose-dependent increase in psychiatric and cognitive adverse events. That's why it is not advocated in patients who are using alcohol or who are using other antidepressant drugs. The topiramate has a chance of metabolic acidosis and renal stone, the contraindication being pregnancy, breastfeeding, hypertension, CAD, co-intake of MAO inhibitors, and there is chances of aggravation of acute angle-closure glaucoma and metabolic acidosis. So these are the trials. The EQUIP, CONQUER, another study is SEQUEL, which actually looked at the beneficial effect. You can see the mean weight loss is between 8 to 12 kgs, which is the highest, and 45 to a staggering 70% of them going on to achieve more than equal to 5% weight loss. Then another combination is naltrexone, bupropion. The bupropion looks at the immediate instantaneous effect of reducing the food intake. Naltrexone basically reduces the hedonic value of the food, thereby reducing the pleasant sensation that we derive from a food. 8 to 90 milligram tablets are available, and up to 2 BD is the maximum dose. The placebo subtracted weight loss is 5 kgs. The common side effect being nausea, constipation, headache, vomiting, dizziness, insomnia, dry mouth. So approved by FDA in 2014. You can look at the doses pattern. Each week the dosage has to go on increase, and the side effects, there can be transient increase in BP and heart rate. This is one major side effect, so it is contraindicated in uncontrolled hypertension, seizure disorder, eating disorder, narrow angle glaucoma, use of other MAO inhibitors, pregnancy, breastfeeding, depression, anxiety, to cite a few. So these are the trials which actually has pushed this molecule as a anti-obesity drug, the COR1, 2 and COR-B mod, and you can see there is placebo subtracted weight loss is somewhere between 4 to 4.6%. So this is the crux of my entire presentation, the studies on various molecules that has propelled these molecules to be used as anti-obesity drugs. And with regards to improvement in risk factors, there is improvement in waist circumference, BP, the cholesterol, the sugar, but the naltrexone, bupropion increases the BP and the heart rate is increased by the naltrexone, bupropion and the liraglutide. The usage in special population, the chronic kidney disease, mild impairment, you can use all. Moderate impairment also you can use all, but the bupropion, naltrexone and the phentermine topiramate require dose reduction. Severe cases, orlistat and liraglutide can be used with high caution. Nephrolithiasis, you are supposed to avoid orlistat and the combination of phentermine and topiramate. Hepatic impairment, in mild cases you can use all. Moderate, again the combination therapies require bit of dose reduction. Severe, none of them are allowed, and the ones who have high chances of developing cholelithiasis, in them liraglutide should be used with caution. Similar is the case with orlistat, and again there is a recommendation that slower rate of weight loss, an increase in dietary fat or administration of ursodeoxycholic acid would do the trick. And you can see a number of comorbid conditions mentioned on the slide, but I can tell you, come what may, whatever may be the comorbid condition, the obesity, lorcaserin are the ones which are safe in probably all of these cases, and liraglutide is the third option which can be used in these comorbid conditions. And if you use antidepressant, these are the ones which produce weight loss: the bupropion, venlafaxine, desvenlafaxine, topiramate, zonisamide, lamotrigine and the ziprasidone, and haloperidol and the aripiprazole being weight neutral. These are the drugs which we can use if the patient is having comorbid depression. We had one review article on the nutraceuticals that are being touted as very promising agents, but the major takeaway point is there are no large scale studies, patient numbers are small, the duration is small, there is poor retention rate amongst these studies. So what are the newer molecules? We have this zonisamide, which is an anti-epileptic. I'm not going to tell you, I'm just giving you a brief overview of what are the ones. Then the tesofensine is another such molecule which again is in the pipeline. And this slide is very important. The left half is looking at the molecules which actually are the ones defined as orexinogenic, or the ones which stimulate appetite, like the ghrelin, neuropeptide Y, the agouti related peptide, and on the right, the ones which inhibit the food intake, those are the leptin, POMC, CART, melanocyte stimulating hormone, the MC receptor. So the basic concept is to block the ones which stimulate the appetite or stimulate the ones which inhibit the appetite. So probably these are the ones which are the targets for the future. And there are some polyagonists, the GLP-1 glucagon or the GLP-1 GIP, or the three of them are being used as co-agonists to give us an additive effect on the weight loss. And there are some conjugates for targeted delivery of nuclear hormones where glucagon is clubbed with T3 or GLP-1 is clubbed with estrogen. I have tried to become parliamentary by using the word gut microbiota transplant because it is being projected as the panacea of all the metabolic problems around, and it is stated that in obese individual there is a reduction in bacteroids and increase in firmicutes. When the gut microbiota from a healthy person is given to an obese subject, there is increase in chances of verrucomicrobiota and gamma proteobacteria, which actually leads to reduction in the inflammation that is found in the obese subjects. So to conclude, probably I will be concluding the entire topic. You can see the benefit accrued out of each and every intervention. The lower to the pharmacotherapy and bariatric surgery, the very important takeaway point is there is a need for diet and lifestyle changes which cannot be done away with. Pharmacotherapy gives 5 to 10% of weight loss. Bariatric surgery maximum, that is 10 to 20%, and there is this structured supported diet or lifestyle program which can lead to achievement of around 10 to 15% of weight loss. Thank you all for that patient listening.
Thank you, Dr. Sunil, for the wonderful presentation.